If someone could make a reality show about your office, what do you think it would be called? Hold that thought till you meet my colleagues. Hey, Babs.
How far, my guy?
Anything for the boys. Gone to the clinic yet?
Nah, I spoke to the doctor via the app.
Hey, Mama. Welcome back, Susan. How was your leave?
Wonderful.
She needed therapy to take care of her mental health. Our HMO really helped with that. Glad she's back to her bubbly self. Wow, that was fast. Thanks. So, what do you think about that reality show?
Nothing beats good health. Do you agree? For access to quality all-round care, home and abroad for yourself, your family, and even your staff, make the smarter choice. Choose Leadway Health, the HMO that offers you more than just healthcare. For more information, visit www.leadwayhealth.com. Leadway Health, for health, wealth, and more.
Good afternoon, everybody. Good afternoon. Thank you for your time. Thank you for coming for this breast cancer awareness session. Let's give the audience like 2 minutes to join. Thank you for coming. This promises to be an interesting and educative session. We have one of the best here to help us and to educate us on breast cancer. I'm welcoming everybody once again. Thank you for coming. We're giving everybody about a minute or so to allow everybody join the session before we kickstart. My name is Dr. Oyinkosola Taiwo. I will be hosting this session, and I am from Leadway Health. So I'll be hosting this session, and let's give everybody about a minute to join. All right, thank you once again, everybody, for coming. Thank you for taking out your time. If you are already in the session, please can you say hello to us on the chat? Just say hi. Just say a comment. Thank you for joining the session. So today we'll be talking about breast cancer. This month is the Breast Cancer Awareness Month, and we just want to learn about breast cancer, learn about the risk factors for breast cancer, how we can prevent breast cancer. We would also eventually, after the educative session, we'll also be talking to a survivor of breast cancer that she will be able to share our experience with us on our journey. So we promise that it's going to be an insightful session, and we're going to enjoy ourselves here today. Right? So let me thank you for coming. We appreciate Miss Grace, Miss Adetutu, Mabel, Kayode. Thank you for coming. Thank you for taking out of your time to be here. Without further ado, I would like to introduce our facilitator for this session. He is one of the best in the field. His name is Dr. Dayo Ajayi. He All right. While we wait for Dr. Ajayi to join, I would like to ask the audience breast cancer, and if you feel like this session will be educative for you.
Good afternoon, everybody. Good afternoon, everybody. It's my pleasure to be part of this unique presentation. The month of October is, as you know, is designated the month for breast cancer awareness. And so this is, it's very apt that this kind of presentation is being organized to even arouse more awareness. And courtesy demands that we thank Leadway Health for organizing this presentation. The color pink, interestingly, is the color for cancer awareness. It's unique because it symbolizes the courage of patients undergoing treatment, cancer treatment, the hope after treatment, and the charitable goodness of hosts and businesses like Leadway Health in organizing platforms like this to create more awareness about cancer. So in the same spirit, I've tried to add a dash of pink to my outfit today to give further encouragement to our patients worldwide. Today, we'll be going through a series of slides, and I hope at the end of the presentation, we would have aroused more awareness and the questions, new things we learned and questions answered at the end of the presentation. Cancer is an ubiquitous disease in the sense that quite often it doesn't give rise to symptoms before it raises its head. There's a lot of research work and new drugs and new innovations being made on a daily basis with a view to detecting, or should I say, preventing cancer in the first instance, because that's the best treatment for any disease. And then when it occurs, to catch it early, because it is generally known that when you catch cancer early, you stand a better chance of curing it. So what is cancer? Cancer is an abnormal growth. The word tumor is used almost synonymously, albeit tumor can be a benign tumor or malignant tumor. So for the purpose of the definition of cancer. Cancer is an abnormal growth which loses control, because there's normally a control on every cell in the body that regulates the number of cells that die, the number of cells that get formed on a daily basis. But when this control is lost, then the cells begin to multiply abnormally. That is it, and out of control. And that is when we refer to it as cancer. Causes of cancer are largely unknown, unfortunately. It remains the devil in the house, actually, because by and large, it's only very few cancers that we can definitively say these are the causes of the cancer. But most times, we know of the associated factors that, through the interaction of these factors, are likely to lead to the formation of cancer. So I'm going to just show you a few risk factors. We're talking about breast cancer now. We can talk about risk factors and associated factors. The risk factors are factors that we know that we are likely to encourage the development of breast cancer. There are some that are non-modifiable. There are others that we can work on. We can't do anything about age because we all age day by day. And we know that the older you get, the more the chances of you developing cancer. And the same applies to breast cancer. So we now know that there are some forms of breast cancer that propagated on a genetic basis. In other words, the breast cancer from the primary family, if you have a primary family of breast cancer. And there are now a few genes that have been associated specifically that propagate this. So the previous history of cancer also puts one at a higher risk. And race, we now know that although in the past we thought that breast cancer was far commoner amongst Caucasians, but we now know that that could be as a result of diagnosis and underreporting, because breast cancer is getting more and more commoner amongst even the black population. And the other thing is that when we see breast cancer in blacks, we see a lot of the aggressive ones, especially in the younger patients than in the Caucasians. We know that previous radiation exposure can also lead to formation of cancer. The factors that we can work on the table on the right of the table, which of the slide, which we can work on: obesity, smoking, alcohol, excessive alcohol consumption, excessive radiation exposure, unhealthy diet, poor physical activity. If you look at all these factors, these are all factors belonging in the day-to-day living of the modern world, when you don't even want to get out of the sofa to turn on your TV, you go to work, by the time you get home, you're tired, you eat late, you go to bed. So, but these are factors that we can work on in our quest to prevent breast cancer. So, like I said, the color pink is the color for cancer awareness. On this slide, you see in a graphical manner the different presentation forms of breast cancer. But I must emphasize that breast cancer, by the time you're finding out breast cancer, you probably have had it for about at least 3 years, because for it to form a lump that you can feel takes at least 3 months averagely. But there are various signs to watch out for, things like change in the breast shape, change in the skin overlying the breast, or whether you are having a discharge from the nipple. Those are signs and symptoms you should watch out for if you want to catch breast cancer early. Breast cancer is the commonest female malignancy. I must warn you, men can also have breast cancer, albeit 100 times less than women. In other words, if you take a population of 100 of patients with breast cancer, 99 of them are likely to be female, and only one of them are likely to be male. So it is also the leading cause of cancer-related deaths in women. Early diagnosis, early treatment lead to better survival. It is, according to the statistics of WHO on Nigeria, is the commonest cancer in women and affects 22.7%, and also is the leading cause of cancer-related deaths in Nigeria. In fact, in Europe and North America, it is generally said that 1 in 13 to 15 women in their lifetime will develop one form of breast cancer or the other. We know it is commoner over the age of 50. That does not mean that you cannot have it when you're less than 50. In fact, the younger you are when you have breast cancer, especially in blacks, the more aggressive it's likely to be. With a lot of work ongoing in breast cancer, we now know that we're not dealing with just one disease. It is a conglomerate of different types of breast cancer. So it therefore makes sense that if we can diagnose the particular type of the breast cancer, we can then give the appropriate treatment to that particular cancer. Therefore, outcomes are getting better and better by the day because we're now able to identify the type of breast cancer and therefore give it appropriate therapy. This slide just tells us the variants that we are now quite familiar with. We know that there are certain receptors that we now use to divide breast cancer into the various groups. By and large, these receptors are the hormonal receptors, and then what we call the HER2 receptor, and the fourth group that you're seeing, in fact, the fourth group you're seeing there is what we call the beta, which is the triple negative. That is those forms of breast cancer which are negative to the 3 common receptors I've just mentioned. What we know is that the ones who have the receptor, the hormone receptors, that is estrogen receptor and the progesterone receptor, they tend to be less malignant, generally speaking, than the ones with the HER2 receptor, and the one in particular, the one that is negative for all those receptors. Up till about 20 years ago, the HER2 receptor types of breast cancer were considered non-responsive to the forms of treatment that were available then, which was chemotherapy. But about 20 years ago, we have made inroads into the treatment of HER2 receptor positive breast cancers because the medication that was when trastuzumab, which was generally called Herceptin, when it was discovered, and it is specific for HER2 receptor positive breast tumors. The triple negative tumors means that they're not likely to respond to the hormone therapy. They're not likely to respond to trastuzumab. Generally very aggressive, and they share the same biological features with ovarian tumors, and there's an interplay with the BRCA1, BRCA2 genes as well in this group. What are the risk factors when we want to bring? We know that there are definitely hormonal factors. We know that the younger you are when you have your first child, and the breastfeeding, and the more children you have, of course, then by extension, the longer you are to breastfeed all of them, The use of oral contraceptives for prolonged periods, especially the combined pills, and the hormone receptor, the HR treatment for menopause, which the combined form. These together form the basis, the hormonal basis for breast cancer. So why does having a child early on confer benefit? Because you have a shorter window between the time that you start seeing your menses and the time you have your first child. So you have a shorter window for the breast exposure to the hormones produced by the ovaries. And likewise, those who have delayed menopause are also exposing their ovaries, their breasts to prolonged exposure to the hormones produced by the ovaries. We've talked about the family history. And briefly, I mentioned BRCA1, BRCA2, and other genes that are now, BRCA just means breast cancer antigen 1 and 2, and all the newer ones that have now been discovered that put patients at increased risk of developing breast cancer. We've mentioned the lifestyle factors, the adult weight gain, the sedentary life, which all lead have an interplay with hormonal basis and hormone predisposed breast cancers. So what are the protective factors? Like we said, less hormonal exposure, having children early, avoid the use of combined contraceptive pills on a prolonged basis, lifestyle changes, exercise, healthy diet. All these will lead to weight loss, and avoid smoking and excessive alcohol intake. But upon all regular checks at designated ages, we will come to this later on. Extreme measure will be what I've written as prophylactic mastectomies. In other words, preventive surgical extirpation of the breasts. The most popular, there are a few popular figures in the social hemisphere that have done this with a view to preventing the formation of breast cancer, without mentioning names. So what are the signs and symptoms of breast cancer? Like I said, by the time you're feeling a lump, the breast cancer in all probability has been coming to being for at least 3 years. So a lump in the breast is the commonest presentation, but there are other signs that we should watch out for. If you know your breast, you will know when there are changes in the breast. So if you see a nipple all of a sudden retracting in, or you see a skin tethering, that is like a dimple in the skin overlying the breast in one part, you should pay attention. If you have a nipple discharge, especially when it's bloody, then that calls for alarm bells. And also, it can present as swelling in the armpits on the same side as the affected breast. The picture you're seeing is what we call the orange skin appearance. Don't wait for this to come up before you see your doctor. This is the skin. This picture comes about because there is edema, that is, there's fluid under the skin, and the holes, the pits that you can see, are the connective tissue that connects the skin to the underlying fascia muscle. So when this fluid accumulates under the skin, it gives an orange skin appearance, and usually it's a sign of advanced cancer of the breast. So the lesson from all this is that we need to know our breasts. And I'm emphasizing again that breast cancer is not just a disease of women, although it affects women 100 times more than men. The male breast is, on the average, much smaller than the female breast, so it is so easy to see if there's a lump there, if there's anything abnormal. But we encourage especially the women to examine their breasts at least once a month. It is generally easier if you carry out this examination within the first 7 to 10 days of commencing your period. And it's better you examine your breast in the morning after shower when there's no grease and oil in the skin, and you can actually have a good feel, which I'll come to that later on in this presentation. This is just a schematic diagram of the anatomy of the breast. And you can see the breast is a glandular organ. The main purpose of the breast is to produce milk. Of course, there are social purposes as well, but the main purpose of the breast is to produce milk to feed the infant. So you can see centrally you have the nipple, and the dark skin around the nipple is called the areola. And then you have the breast proper, that is the glands, intermixed with fatty tissue and connective tissue under. And we tend to regard the breast and the armpit as one unit. You will see the importance of this later on in this presentation. So here we are. This is a bird's view of the breast and the adjacent armpit, which forms a unit as far as breast cancer is concerned. So to examine your breast, you have to examine your breast standing up and lying down. So you've had your shower, you stand in front of the mirror, you elevate your arms, you can see, like I said earlier, you know your breast, so you will know when something different is happening. So if, for instance, the nipple that used to be high, because the two breasts are never the same. One is usually bigger, and the nipples are hardly ever on the same level. So even one that was on the lower level before, all of a sudden, you can see it going up, alarm bells. So you stand in front of the mirror, turn around, left, right, and have a good look, and reassure yourself that there's no change noticeable. Put your arms down, put them on your waist, turn around, have a look, press your arms on the waist, that is, tense your muscles to see, turn around again to see if there's anything new that you can notice. After you've done that, then you lie down with a pillow under your head. You examine the right breast with your left hand and the left breast with your right hand. And when you examine the right breast, the right hand is better under your head, because this will expose the armpit as well as the whole breast. So if you look at it, regard it as the face of the clock. So make sure you go right round from 12 o'clock to 1 o'clock to 2 o'clock, go right round until you come back to 12 o'clock. And you examine, that is, you rub the flat part of your fingers against your rib cage in a concentric manner, and go right round to see whether you can feel any lump. And lastly, you come back to the center of the clock, that is the nipple and the areola. You rub it against the chest to see whether there's any lump palpable, in other words, that you can feel. And don't forget, at the end of it all, you still stand up and do the same thing. And at the end of it all, you press the nipple to see whether there's any discharge. Squeeze it, just squeeze it a bit to see whether there's any discharge. Of course, for people, you will have a milky discharge if you just had a baby or you're pregnant. But when you start seeing a bloody discharge, then you should go and see your doctor. So we've talked about lifestyle modifications, the diet, and more emphasis is placed on that now, because the vegetables are a good part of the diet that help prevent breast cancer. Exercise regularly, low intake of the bad fats, and stop smoking, and reduce alcohol consumption and exposure to radiation. Breastfeeding is well known to be a protective factor. Again, it is generally thought that this has an interplay with the hormonal levels. Now, regular screening is an established thing in the Western world, and it's in the case of Europe. In Europe, it's mostly organized by the government, and write you letters when you reach a certain age. We'll come to that later on. In America, it's also well established of course, with financial tied to the financial factors as well, because mostly borne by insurance companies. So, what are the advantages of breast screening? It reduces the risk because early detection, don't forget that we said early detection, the smaller it's likely to be, and the more likely the more you are to, the more likely you are to be able to cure it. So we've talked about self-examination, but when you subject yourself to breast screening, there is a particular triad of things that you do. That is the clinical examination. The doctor will examine you methodically, just like we discussed earlier on. And then you have a mammogram done when you've reached a certain age. That is, when you're above 40, you can have a mammogram. If they're less than 40 and there's a high risk, that, in other words, you have a family history of breast cancer and you want to subject yourself to screening, then ultrasound scan is more useful in the younger patients. And if there's any suspicious lesion, you can have what we call a needle aspiration. Now, the thing about needle aspiration is that in centers where in centers worldwide, in Europe and the Americas, you have designated centers for fine needle aspiration. So this is what they do day in, day out, and therefore they have a higher degree of success with it. The fine needle aspiration is good because before the lump becomes palpable, that is, before you can feel the lump, if you catch this on mammogram or the ultrasound scan, you can actually put the needle into the suspicious lesion and aspirate cells and send to the lab for assessment. This is a typical picture you get in mammogram, which is, by and large, nowadays is a digital image. Gone are those days when we used to use the old films. This is a digital image, and you can actually see lesions with calcification and distortion of the architecture. And this is a graphic image of what we do when we see a lesion and we stick a needle into aspirate cells for diagnosis. So, what age should we screen? There are various groups coming up with various recommendations. But before we go into this, if you come from a family with a positive family history of breast cancer, even as young as 20-something, you should start examining yourself and subjecting yourself to regular checks. So, but these are just general guidelines. Once you reach the age of 40, the American Oncology Society will say you should be subjecting yourself to screening on a yearly basis from 40. But some people will say, well, maybe too yearly, but then definitely when you're 45, you should be subjecting yourself to screening yearly. Between the age of 50 and 75, 2 yearly is generally thought to be adequate. And after the age of 75, routine screening is not recommended, except if you only subject yourself to screening if there is any symptoms or signs that you're worried about. In the UK, it is recommended by UK breast cancer screening that between the age of 50 and 70, you should come for 3 yearly screening. There are other tests, ancillary tests, apart from the mammogram and the ultrasound scan. The MRI is useful for patients for younger patients when you are not too sure what you're seeing on the ultrasound scan. And the 3D mammograms are now getting more and more commonly applied in screening exercises. You can also have nuclear imaging, whereby you get injected with a radio-labeled isotope, and you scan it with a gamma camera. The PET CT scan is not usually used for screening. It is usually used in monitoring patients' progress, but it can also, it's much more sensitive and specific than all the other tests, but it's much more expensive as well. If you see any lesions after carrying out the aforementioned tests, you recall the patient and you carry out, if you haven't done a fine needle aspiration cytology before you do that, or a core biopsy, which can easily be done with vacuum assistance, and rarely do we go on to do incisional biopsy or excisional biopsy. The reason why the latter two are falling out of favor is that when you do this, there's a tendency that when in the process of fiddling with the tumor, there's a risk of pushing cancer cells into the bloodstream. So it is generally discouraged. So you've done the screening, you've picked up the lesions, you've done the test, you sent to the lab for analysis. And these three factors are what the pathologists use to characterize the tumor. It stands to reason that if the tubules, we talked about the breast as being a gland. So what does the gland do? The gland secretes into the cells, the cells express the secretions into the tubules, that is the ducts that carry the milk, which in this particular instance is the milk we're talking about. So if on histology, the tubules are well formed, that is a good sign, because it means even if this is cancer, it is likely to be less aggressive. Then the mitotic count is the number of cells dividing under the microscope. So that is also one of the tools that the pathologists use. And the size of the nucleus and the pleomorphism is just the different shapes the nucleus is assuming. The more you have this, then the more aggressive the tumor is likely to be. There are other features, like are the tumor cells going into the lymphatics? Are they going to the blood cells? Are they going around the nerves? And these are all descriptive terminologies that the pathologist will provide to help in reaching a decision on how aggressive the tumor is. Generally, these three factors are used to score the tumor, and the higher the score, the more aggressive the tumor is. So we also have the descriptive histology. In other words, they will tell you, oh, this tumor is coming from ducts. So if it's infiltration, in other words, it's cancerous, they'll tell you it's infiltration ductal cancer. If it's coming from the lobules, don't forget that we talked about the breast as a gland. So the lobules are the cells producing the milk itself. Then we call it infiltrating lobular cancer. There are other descriptive terminologies like medullary, which you find in younger women, the mucinous, that is, it secretes mucus in older women, and the papillary cancer, which are more centrally found deep in the breast, and the metaplastic, which is common amongst Black people and unfortunately more aggressive. Paget's disease is when the tumor arises in the areola, around the nipple. It generally runs a more indolent course than the aggressive types of breast cancer. So you've made a clinical diagnosis, you've taken your sample, sent to the lab. I'll just spend 1 minute or so on this particular descriptive type of breast cancer, which is called inflammatory breast cancer. It mimics inflammation, it mimics infection. I've had a few patients over the years who thought they were dealing with infection. It mimics infection in the sense that there's the cardinal signs of infection, the color goes red. So there's reddening of the skin. It goes warm. Anybody who's ever had an infection like a boil, it's warm to touch. And there's a swelling there. It goes red because there's inflammation of the surrounding skin. And this type is usually more aggressive. It takes a more aggressive outlook. And it's commoner in Black people and in younger patients. So, to help us in treating breast cancer, we stage the tumor. So you've made your diagnosis. The next thing you want to do is to know what stage is the tumor. The earlier the stage, the more the chances of cure. So in other words, we have the early breast cancer will be local and localized to the breast itself. If it's extended to the armpit, it's become regional. In other words, if you have glands or swellings in your armpit, it's become regional, but still the same. We regard the breast and the armpit as an entity. And of course, if it's gone into the bloodstream, gone elsewhere, it is therefore metastasized. In other words, you need a form of systemic treatment or the other. We've talked about the biological types profiling of breast cancer and the various categories. The other tool that we now use a lot is called the immunohistochemistry. You've made a diagnosis of breast cancer. You need to subject it to immunohistochemistry, which will tell us what type of breast cancer you're dealing with. So don't forget, earlier on I told you there are 3 parameters we use: the estrogen receptor, the progesterone receptor, and the HER2 receptor. And depending on which ones of these are positive or negative, you now know what type of breast cancer you're dealing with. You will now combine this with the histological grades and features that we discussed earlier on to prognosticate, in other words, to know how aggressive this tumor is likely to be and advise you on the most appropriate treatment to embark on. So, in terms of staging, when it's caught early, we say stage O, that is sleeping cancer. And these, more and more of this we're getting now with widespread screening. So you're catching the breast when it's still sleeping. And unfortunately, this creates other issues, but we'll come to that later. So when it's still in the breast, but tiny, we call it stage 1. When it's sizable with nodes in the armpits, which are discrete, in other words, they're not joined together, stage 2. Stage 3, when it's spread to adjacent muscles and the nodes in the armpit are all stuck together. And stage 4, when it's gone far away to other organs. There are other types of staging, but we will not go into this for the purpose of this discussion. So, what is the aim of treatment? The aim of treatment is to cure. So, like I said earlier on, the earlier you present, the smaller the lesion, the earlier the stage, and the more likelihood of success in curing the cancer. So, surgery could be in form of just removing the lump, if it's just a tiny lump. And if it comes back, or if you know before you remove the lump, which you should, then you may decide the margin of skin and the margin of tissue you're going to resect with the lump. Sometimes you're not sure, you do a lumpectomy before you know it's cancer. You may still have to go back. If a wider excision form of treatment is appropriate, you may still have to go back and take a bigger cuff of tissue around it. We are getting more and more patients suitable now for conservative mastectomy. That is, you're catching the tumor, either you're catching it early when it's still within the breast and it's not big, or even when it's, especially nowadays, even when you think it's locally advanced, and you subjected the patients to treatment before surgery, which we call the neoadjuvant treatment, either in forms of chemotherapy or the specific therapy agents, depending on what type of breast cancer it is, like Herceptin or pertuzumab. And we are, to a large extent, able to downgrade the staging of the tumor that makes such tumors amenable to conservative mastectomy. In other words, instead of removing the whole breast, you're able to remove a part of the breast, a quarter of it or half of it, and gives you a better aesthetic outcome. Mastectomy, when the tumor is advanced or big or locally extending to the adjacent tumor muscles and fascia, mastectomy. But you still think that you can remove the whole tumor with a view to curing the patient. In those days, we used to do very radical procedures like removing even the muscles, underlying muscles, and stuff like that. But nowadays, mastectomy is likely just removing the breast and test whether there's nodal involvement in the armpit, where you have the facilities. You can do a sentinel node biopsy and get your answer immediately, then decide on whether you're doing axillary clearance or not. So you've done the operation, performed the operation, and you now know what kind of tumor you are dealing with. And at this point, I would like to add that even though you do your biopsies before the operation and you subjected the tissue to immunohistochemistry, I think it's still advisable after removing the breast itself to subject it to immunohistochemistry as well, because there's what is recognized, well recognized, that there may be a variance between your outcome after the whole breast is removed or the whole tumor is removed to what you got before surgery. So then that will advise you on whether you go ahead with hormonal adjuvant treatments. In other words, the tablets like tamoxifen, like anastrozole and letrozole. And then radiotherapy is also an integral. After you finished all your chemotherapy and everything, you send for radiotherapy where appropriate for further treatment to give the patient the best chance of non-recurrence. Common side effects of chemotherapy are well known. And what we tend to do, tell our patients, look, most of these side effects are reversible. Hair loss, but then, thank God, there are all sorts of wigs available now that many times you're not even sure whether they're wearing a wig or there's the hair. So that is no problem. Weight loss, you prepare them for. Anemia, because what the chemotherapy agent does is that it attacks the fastest dividing cells in the body, which for the moment the cancer is there, is the cancer. But unfortunately, other fast dividing cells like the hair, the blood cells, they take a big hit as well. And in the case of the white cells, it predisposes patients when the white cell count is low to infection. So nausea and vomiting are also well recognized, and you prepare your patients for these side effects. These are just pictures of patients who have had chemotherapies. You can see the skin changes in the hands, which is typical of a particular type of chemotherapy, oral chemotherapy agent. So the advent of widespread screening is creating a new headache, because we're now having an increased pickup rate of cancers, sleeping cancers, that is, cancers that are dormant. They have not yet become active. And what to do with them many times creates a dilemma, because you don't know whether you need to treat by way of radiotherapy or whether you need to treat by drugs, or some people will even opt to have both breasts removed completely, that is prophylactic mastectomy. So those are the forms of treatment available for sleeping cancers. There's life after treatment, in the sense that we now know that we can beat the cancer, we can beat breast cancer. And when we cure breast cancer, there are various procedures that we can now undergo to regain the shape, that putting a new breast or creating a new breast and all sorts like that. So these are now available to a large extent. So because especially in our society, the aesthetic value of the breast is very well recognized. But you tend to tell our patients that there are all sorts, even if you're not going for immediate reconstruction, there are all sorts of contraptions that you can put in that nobody will know apart from your partner. This is the external breast prosthesis, which you can put in the bra immediately after the operation. So even when you leave the hospital, you're going home, nobody will know. In this particular patient, you can see that they had a local treatment, that is conservative resection on the right, and which was filled up later on to give a perfect result. You can have two for the price of one. I tell my patients, you have a flap of fat from the lower part of your abdomen and to fill the gap in the chest. So you have a tummy tuck as well as a new breast. This is a lady who had bilateral mastectomy and then reconstruction. And you can see that even the nipples were reconstructed eventually as well, satisfactorily. So after breast cancer, you are able to do almost anything. Go back to your routine, and psychologically, you should be prepared to face the world. Giant strides have been made of late in the areas of molecular biology, and newer and more effective chemotherapy and biological agents are being discovered and utilized on a daily basis. Reconstructive surgery to lessen the psychosexual setbacks are now widely available as well. The unfortunate thing in our local reality is that there's no government-organized screening program. So we can only encourage advice and awareness to reach as many people as possible. The rich versus the poor divide still, unfortunately, still plays up because these procedures are not cheap. Even in the government hospitals, you still have to pay for most of these procedures. So on behalf of Redemption's Medical Center and Leadway Health, I thank you very much for listening to me this afternoon. And I hope you've had an enjoyable session. Thank you.
Thank you, sir, for your time. Thank you for the insightful and educative session. We are grateful for you taking out time to assist us in this session. We've learned a lot. Thank you for letting us know that indeed we can beat breast cancer and it's not the end. For even letting our ladies know that you can even do 2 procedures, get a tummy tuck, and at the same time a new breast. At the same time, if you decide to opt for reconstructive surgeries. At this junction, I would like to introduce to ask the audience to ask any questions they have. We'll be taking about 2 questions because we've run out of time. But if anybody has 2 questions for Dr. Ajayi, please, this is the time when you can ask your questions quickly. Any questions? Okay, so at this juncture, if we have questions for Dr. Ajayi, I would like to believe that we've been able to learn all we need to learn in this session. Sir, just one question from my end, just to remind the audience. Some people are asking, what point exactly do they need to do mammogram? Do they need to screen for breast cancer?
I would say that from the age of 40, yes. But I did say earlier on in the presentation that if you come from a family if you have a family history of breast cancer, even much more earlier, even in your 20s, be conscious of your breast and examine yourself regularly, and if necessary, subject yourself to ultrasound scan, in some cases MRI scan. But once you are over the age of 40, mammogram is an integral part of the investigation, because by then the mammogram is sensitive enough to pick up abnormalities, because the breast is less dense, and the mammogram is used in conjunction with the ultrasound scan and of course the clinical examination to form the triad of investigations for breast cancer.
Thank you, sir. So someone is also asking, how long after surgery can they do a reconstructive? How long after the breast removal surgery can they do the reconstructive surgeries?
In some instances, it's done. It can be done combined, but of course that prolongs the operation. So I would say if you've had your mastectomy and you want to do reconstructive surgery, by the time you wait another 2 months or so, you are ready for the reconstruction.
Thank you, sir.
Of course,
Another question.
That's dependent on the other forms of therapy. I would say 2 months after finishing all your treatments, should I say.
Okay. So another question says his wife just did FNAC, and biopsy. He's asking what is the way forward after the FNAC and biopsy.
The waiting time. You can carry out a fine needle aspirations in cytology immediately.
No, the way forward. What next?
The way forward.
Yes, sir.
The way forward. Well, some laboratories do FNACs. They give you reliable answers. But you can only aspirate what you see or what you can see on the ultrasound scan or what you can feel on clinical basis. So, like I said earlier on, avoid doing incisional and excisional biopsies when you have not come to the conclusion of what exactly you're dealing with. So you use a combination of the FNAC and core biopsy to get your tissue diagnosis.
Thank you very much, sir, for that answer. Someone is asking if reconstruction can be done in Nigeria.
Yes, reconstruction can be done in Nigeria. I did not elaborate. If you want me to take you back to the slide, I can. But the flap technique can be done free or on a pedicle. In other words, tunnel. When you've cut the skin from the lower tummy and you tunnel it up to fill the vacuum left. But more and more of these procedures are now done free. In other words, you cut off the blood supply there and you join it under the microscope to the new site, to the blood supply in the new site. They are being done locally because we have plastic surgeons who come from abroad as well and do that. I have, since I came back, I have done a few flaps on pedicles. In other words, not the microscope, but even the microscope, people come from abroad and do microscopic anastomosis.
Thank you, sir. So the last question that we have is from a lady that is asking, she has a lump that appears during her period and it disappears after her period. Do you have any comments to that, sir?
Well, like I said, any lump should be properly looked into. So it depends on what is coming. In the run-up to the period, the breast becomes engorged. So it may be due to the fact that the lump becomes engorged and then it's more palpable. But I think any lump in the breast at all should be investigated.
Thank you very much, sir. I think one thing we should take from the question and answer session is any lump should be investigated. So regardless of the period of your time of your cycle or regardless of when you notice the lump, any lump should be investigated. And we are also aware that reconstruction can be done in Nigeria under proper guidance. And you make sure you please go to registered qualified medical practitioners to help you with your reconstructive surgeries instead of visiting people that are not certified and we have complications ensuing from there. It's very important to remember that. Thank you so much, sir, for your time.
Last word.
Very grateful.
Sorry,
yes,
Dr.
yes.
Taiwo. I think I forgot to put this in the slide, and it's a very important one because I've had many patients since I came back. You diagnose cancer, they disappear, which is normal because the state of shock, state of disbelief and everything. But we need to encourage our religious leaders, that is the pastors and the imams, not to prevent them from availing the treatment in the sense of the opportunity to get treated medically, to encourage them and support them in their faith, not keeping them away from the hospitals. That's very important because most of these patients will come back 2-3 years later on when it's far too gone to treat.
Yes, sir. Sorry, one last question. Someone is asking, after removing a lump, can breast cancer still occur after a lump is removed?
Yes, that's why I went through the pain of telling us about the stages, and the chances are better when the smaller they are, the chances are better of cure. So it can be cured. but we need to be vigilant so that we can catch it early and give ourselves the best chances of cure.
Thank you, sir. Catching it early and the best chance of cure. That's my key point from that statement. Thank you so much, sir, for your time. Thank you, everyone that has been here. At this point, we promised, or we would like to talk to one of our survivors. She's a breast cancer survivor, and she has accepted or decided to come and share with us her story today, her journey throughout the process of breast cancer and life after breast cancer. Because the theme for breast cancer this year is living, beyond breast cancer. Is there life after breast cancer? So I would like to welcome Mrs. Queen. Thank you so much, sir, for your time. I would like to welcome Miss Queenette right now to the stage.
Everybody in the house.
Good afternoon, Miss Queenette.
Hello.
How are you doing today?
I'm fine.
Okay.
Dr. Dayo, good afternoon, sir.
Good afternoon, Miss Queenette.
Yes, sir.
Thank you so much, Ma, for joining us today. So we just like to ask you for a summary of your journey, how you were diagnosed of breast cancer, how you noticed it, and what you've done so far.
Okay, thank you. The journey started in 2019, July. When I was sleeping after my fasting, I just slept. I just saw that near my breast. I just touched my breast. I didn't even have any intention. After touching, I saw something like stone. And I called my younger sister. I said, I have stone near me. She now said, maybe it's my period. And I said, okay. After my period, the stone is still there. She now said, okay, I should go to hospital so that they will observe me and know what next. When I went to hospital, they said I should do test. I did test. They said I should do a scan. I did everything. They now said they are seeing something like lump, that it will be removed. Then I did they removed the lump in August period, in time of August. After removing the lump, they now took it to lab and said they will give me feedback after 1 month. After 1 month, the result came out that I have cancer. That was in September. My doctor, it was not a small journey. The day they told me, it looked as if maybe I should just give up. But fortunately, I just picked up the courage. I said, let the will of God be done. Because the way the doctor just tell me, the breast will be cut off. There's no word of telling me, and this how you just said your breast will be cut off so that you'll be on a safe side. I went home. He said after 2 weeks I should come back. I didn't go back. I went around. I went to different hospitals to see maybe I can find a solution. After 1 month, the doctor called me and said, come back and do this thing. The earlier you do, the earlier you leave. That is where the operation was taken. I did it in November 2019. After it was successful. They discharged me. Then as I will go for my chemo, I did my chemotherapy, 6 sessions. After chemotherapy, I did my radio. After radio, normal again. No, I will say the truth. That is my journey so far.
Well, we just have to give you kudos for coming up to share your experience with us. And like I said earlier on, when you're embarking on this journey, you need all your ammunition, your faith, your energy, diet, everything. So we don't want to see patients who come and then disappear and then they say it's not their portion. They go and pray. Yeah, prayers are powerful, but the things we do, the drugs we use are God given as well.
Yes.
So thank you for coming to share your experience.
Thank you, doctor.
Thank you very much, Ma, for sharing your journey. We'd just like to ask one last question to you. After the surgery and after the chemo and radiation, we are happy to see you here living healthy. But how has life been after, your treatment for breast cancer? How has life been afterwards?
Dr. Taiwo, thank you for your question. The journey is not easy. I would rather say the truth. No father, no mother, no husband. The journey was not easy because anything you want to do about this cancer is the money. I have the lady we started this thing in 2019. She ran away because she was saying, are they going to cut her breast? She's still going to have one breast. I said, my sister, so if I can have one breast, I want to live. I'm a survivor. Outside, what they call me is Osha Prapra. I need the light door moments. Some people don't know I have one breast. Unless I come outside to tell you I have one breast. It's not easy. But finally now, she by next week now, they are going to cut off her breast. I told her that time, let's go. She said, you can't carry one breast, so her husband can all those kind of things. But it was not easy. Only money. Till now, I'm still paying back debts. Till now, I'm still paying back debts. No work, nothing. But my church came upon, my fellowship, friends, people around, family. I sold some of my daddy's property. It was not easy. But I give God all the glory that me, Osha Prapra, can stand today in the presence of my doctor Dayo to say I'm a
Thank God.
survivor.
We thank God. We thank God. We thank God.
Thank you very much, Ma.
You
Okay,
just
go ahead,
brought
sir.
an important point there. It's a very expensive venture
Yes.
on all fronts, on all fronts.
Yes.
Not just the cost of the surgery or anything. More and more nowadays, the cost of the medications and injection and the treatments, chemotherapy. So it is something you have to be prepared. I mean, if it was even in places where the government supports treatment of cancer, it's becoming a problem because there's some of these medications that can cost as much as $10,000, $20,000 every month. So we thank God for your life. And
Doctor, I want to ask questions because
yes,
this thing you said now, there are three questions I wanted to ask, but fortunately you answered the two beautiful ones. The first one is that we should not listen to anybody that is, you have cancer. Let me read the cancer. Let me go to Alagbo. I have
exactly.
the lady that have the cancer because of money. She stepped away since 3 years. As at last month, the breast cut off in the passage. Before they could have rushed her to Bagada, she just gave up. This issue we are passing is what we are talking about is money.
Yes.
And as I'm using cloth on my own now, I saw the way you bring up people that did their surgery with their body.
Yeah.
And that is mine at my age.
You are
As at
young.
now.
It's screen that you're still very young. You're
Eh,
looking good the way you are, but
eh,
yes, there are options if you want to explore that. Yes, you're still
I
young.
wish you.
Thank,
I wish because
thank you very much,
if
Ma.
not because of our doctor Tayo that is here, I could have shown you. But
Please, we are live. Thank you very much, Ma, for your time. Thank you.
Thank you.
I would also like to thank Renaissance for helping us to make sure Dr. Ajayi is here today for all your reconstructive surgeries. His facility is one of the best in Nigeria, and that's why he was proudly saying that do reconstructive surgeries here in Nigeria today. So you can always visit Renaissance Medical Center if you have any concerns or issues concerning breast cancer. I would like to thank everyone for coming for this session. We appreciate your time. We also want to thank Ms. Quinette for being here today. Last thing I would like to mention on this session is that we'll be giving free mammograms to each and every one of people that have mentioned or said hi on the chat today or have asked the questions. So to claim your voucher for the free mammogram, just send us a DM on social media, on any of our social media platforms. Just send us a DM with your name and phone number and your email address, so that we will send you the voucher for free mammograms. You can always redeem it for a friend or for a family member or a colleague that you feel has complained to you about for lump in the past that you believe should benefit from doing the mammogram, which Dr. Ajayi has explained that is necessary for one of these steps for screening for breast cancer. So just DM us. We've taken note of everyone that has said hi to us on the chat or has asked a question. So you can just DM us on any of our social media platforms. Thank you once again, everyone, for attending this session. I hope we've been able to pick one or two things from this session. Thank you, Dr. Ajayi. Thank you, Ms. Quinette. Thank you to Leadway Health for making this section successful. We are a health insurance company here to serve you, here to give you the best of services. And you can always reach us on any of our social media platforms. Our website is www.leadwayhelp.com. And you can always email us at healthcare@leadway.com. At Leadway Health, yeah. Thank you very much for
Thank
your
you.
time. Thank
Thank
you,
you.
sir.